course, liver biopsy rely on an invasive procedure and approach. So there has been a great deal of attempt over the years to develop non-invasive tests. This is the one that's used. There is a lot of these algorithms, clinical tests that people actually use from existing clinical data to predict if someone is at high risk. And this is the FIB4, the most commonly used test. The parameters are there, and actually it's in the internet. You can put in the numbers and get a number. I'm not going to go through the cutoff. The cutoff that you have to remember is 1.3. 1.3 is one. Lower than 1.3, basically you exclude patients who are at risk for more adverse outcomes. Another, of course, modality is imaging modality. This is really to measure stiffness of the liver. Now, stiffness of the liver does not mean fibrosis. That's actually a surrogate. And there's more and more data suggesting that transient elastography, measuring stiffness of the liver, is a good surrogate or predictor of outcomes. And there are different ways that you can measure it. By ultrasound, of course, here's liver stiffness assessment. Transient elastography, there's ultrasound. There's also MR elastography, which probably is a little bit better than transient elastography in terms of accuracy, except that it is also more expensive. It's available readily. So people are using more and more transient elastography to sort of risk stratify patients. Now, there are also a number of efforts to combine transient elastography or MRE or MR elastography with other clinical tests. This is one called FAST, which combines CAP, which is the measurement or continuous attenuation parameter that measures actually fat, plus stiffness, plus an AST to calculate basically FAST score that probably is a little bit more accurate in terms of not only giving you stage of fibrosis, but some idea in terms of activity, in terms of steatohepatitis. There's also MFIP and others that use MRI to do this. There's a different version of this that's called Agile 3 and Agile 4, which basically actually gave you a better idea in terms of what are patients with F3 and F4, what kind of outcomes they will have. Those are not really used that readily in practice, so we just suggest focusing on FIB4 and transient elastography. That would get us where we want to be. Serum biomarkers, there are a number of them. ELF, ProC3, there are others that are being developed. ELF is the one that was approved by FDA for prognostic and sort of biomarker for actually even NASH. And it's, of course, is a combined of three different sort of component: hyaluronic acid, P3NP, and TEMP1. These are sort of fibrogenesis and fibrolysis sort of parameters. And in general, they perform very well. All these non-invasive tests have high negative predictive value, meaning that you can exclude patients with advanced fibrosis. They have had trouble with positive predictive value, meaning that can you actually identify patients who have cirrhosis with these tests? And I'll show you some combination that could help. Then in terms of cutoff, 11.3 or higher is actually problematic. That's where you see cirrhosis, and the outcomes are pretty bad. 7.7 was the cutoff that was used as a lower threshold. I think that is too low. That actually basically, almost everyone will have a threshold that's going to be outside this. So there are actually recommendations to change that threshold, and probably in Europe it's 9.8, and in the United States there is some effort to look at 9.2, alpha of 9.2, to identify patients who have stage 2 fibrosis or F2. Now, in terms of the this is of course MRE, as I mentioned. Again, an MRE's sort of stiffness of 3.2 will get you in those patients who are at high risk. So NIT predicting outcomes, this is the FIB4 story. This is almost 20,000, over 20,000 patients followed up. And if you actually look at those patients that have high FIB4 or those who have intermediate FIB4 and then low FIB4, both those groups of patients that come in with very high FIB4, 3.25 or higher, they are at higher risk of adverse outcome. Or if actually the FIB4 increases over time, that also would indicate more aggressive outcome. Now, in terms of transient elastography, this is again looking at stiffness, but also at CAP. Again, those patients that have higher stiffness, this is from Haynes, they also had higher rate of mortality or lower survival. There's some suggestion that also CAP can be a good predictor of outcome. 285, CAP of 285 or higher has been one of the cutoffs that's been used. I don't really look at CAP as much as stiffness. So in my view, stiffness is probably what you need to look at. Now, in terms of ELF testing, this is a study we published in gastroenterology a few years ago. Again, if you get an ELF score of 11.3 or higher, both in F3 and F4, it's basically predictive of adverse outcome. So these non-invasive tests not only can give you an idea about where the patient is in terms of their stage, but also as a good predictor of long-term outcome. And finally, when you look at MRE and look at different sort of thresholds here, when you get to about MRE of about 4.39, then you've got cirrhosis, 6.88 and higher, that's basically decompensation. And as you go on that scale higher, you can get to the stiffness with by MRE that basically predicts either the complication of cirrhosis or even death. So the guidelines have been developed to actually look at these NITs to risk stratify patients, because yes, if you have 38% of general population having MAST-LD, you need to find those patients that are at highest risk. And now, of course, with the treatment that's available and it's FDA approved, as you heard during the break, that's for F2 and F3, you need to find those patients. So risk stratification is part of what guidelines have done. This is 2022 guideline from ACE, which is American Association of Clinical Endocrinology. I was a part of that. Now, remember, if you look at the left, they're looking at those patients who are at high risk clinically, so diabetics, pre-diabetics, obese, especially with what cardiometabolic risk. And then we're looking at a FIB4 first, and then using FIB4 and to risk stratify further for second line NIT testing, which is either transient elastography or ELF testing. I can tell you that I'm also a member of the ADA guideline. This is probably going to be simplified because we probably wouldn't just need one cutoff for FIB4, 1.3 high or low. And the most recent guideline that's been published is actually the EASL guideline, came out about a month ago or so, and that still has the three cutoffs of 1.3 to 6.67, and then 3, and then the higher rates of the higher values. So then the three sort of categories would confuse people. So I think the two categories, at least where this test would be important, which is in the primary care setting and the endocrinology setting, the 1.3 cutoff is really the one that I actually advocate. And of course, once you have that, then of course the referral to gastroenterologist and hepatologist is warranted, where the second line actually testing with NITs are done, and then you can decide on treatment. So if you have a transient elastography of on the second line of less than 8 kilopascal, those patients can be sent back to their primary care and not to be worried, and the other patients would be followed. Again, this is the AACD guideline, NITs that came out last year, very similar to the ACE guideline, very slight differences in terms of their approach. So again, they have the FIB4 has the three sort of categories, and for a primary care, we need to simplify this. So we are leading a global effort to simplify some of these guidelines and come up with a unified approach to how to actually use these NITs and where the treatment should come. And of course, once you identify the patients who are at high risk, then you basically address their cardiometabolic risks with lifestyle intervention, but also by addressing their metabolic sort of condition. So if they are diabetic, they have to be on appropriate diabetes anti-diabetes medication. If they're obese, you have to manage that. But that doesn't mean that you have to ignore their NASH, because there is actually a NASH targeted therapy that needs to be used. So that sort of conversation needs to happen in the offices of gastroenterologists and hepatologists. So when you look at these tests and you look at what are you going to use to do what, that if your sort of approach is to identify those who have advanced fibrosis, then these are the thresholds that you have. If your approach is to find cirrhotics, meaning that those that you need to screen for hepatocellular carcinoma, that you probably sometimes should think about sending into Rohit for a transplant evaluation or other things, then the threshold is different. The challenge here is that the non-invasive test for F2 is not very good. Even the alpha, and I think there are two major consortia, one in the United States and one in Europe, Litmus and Nimble, that they're trying to actually develop some of these NITs, and hopefully in time we'll have better tests that can not only tell us where a patient is with F4 or F3, but also with F2, because F2 is where these risks will increase. So I think we have had a great deal of understanding of this disease. I've been in this field of fatty liver disease since it started in 1996 or so. So it's been a long journey, but I think we have the new drug and a few great NITs that's been developed. So I'm going to actually move this to Dr. Banzel to come up and give us a talk about the lifestyle modification, but also treatment with drugs that we have. So thank you very much for your attention. We'll take questions at the end. Thank you.